So I'd like to introduce right now our speaker, Dr. Li Zhou. Li Zhou is a general cardiologist with Norton Heart and Vascular Institute and medical director of the Norton Heart and Vascular Institute Women's Heart Program. Dr. Zhou earned her medical degree from Zhejiang University School of Medicine in Hangzhou, China. Her doctoral degree in pathophysiology from Peking Union Medical College in Beijing, China. She completed her internal medicine residency at Jacobi Medical Center of Albert Einstein College of Medicine in the Bronx, New York, and general cardiology training at the University of Illinois, Chicago. She advocates for women's health because heart disease in women is often underrecognized and undertreated. Her expertise and special interest are in the management of heart diseases during pregnancy and peripartum. Welcome, Dr. Zhou.
Thank you, Dr. Jennings, for introducing me and inviting me to this talk. Today, I'm going to talk about what happened to her heart. I do not have any disclosure. So the first case is a 73-year-old Caucasian female with a history of hypertension, hyperlipidemia, and diabetes. She came to me with indigestion. It's around her epigastric area, mostly after she's eating, and sometimes also happening when she's having showers or when she rushes up. Social-wise, she does not have any toxic habits, went through one pregnancy without any complications, and delivered her child vaginally at 40 weeks with a normal birth weight. Family-wise, her brother does have MI in his 60s, and her mother had diabetes, but no sudden cardiac deaths in the family. Otherwise, she was already seen by my partner before she came to see me, and because of complaints of chest pain, she had a nuclear stress test, which was negative in February 2021. And again, when she went back, she was still complaining of chest pain, so the other provider ordered a CT angiogram, which was done in June 2021, showing that she had a little bit calcification in her coronary artery system, but not very high, a score of 74.2. And overall, she had mild to moderate coronary artery disease. Then they performed CT-FFR, which was negative. So she got reassured, but somehow she still gets bothered with the indigestion. So she came to see me and hoping that I can help her out. Knowing what's happened, not far ago, I was wondering what should I do with her case. She does have risk factors and, also has family history, even though not very early or premature onset of coronary artery disease. So we had a lengthy discussion. Her features was concerning, especially when she has this indigestion, when she's rushing up, make me worry whether her right coronary artery is having some issues or not. So we ordered a stress test when she first see me in November last year. And interestingly, her echo looks okay, but she was positive on her EKG. Even though, many times we go with echo because it's more sensitive, but they don't always overlap with each other. Knowing her history, even though she had a CT angiogram back in 2021, we still decided to proceed to left heart catheterization for a definitive answer. So here is her still image of her coronary angiogram. You can clearly see that she had a very tight, let me show if I can, I can see, show you. So she had a very tight proximal left circ, end up with a stent in this area, and her indigestion got finally resolved. So this figure is showing you that coronary artery disease, even though the mortality rate, looking at the absolute number, is slightly higher in males, but still the #1 killer for females. It kills more females, than all cancers combined. If we look at coronary artery disease, in different states, Kentucky actually has moderate burden of coronary artery disease. This is the data from CDC back in 2021. It killed more than 11,000 people in Kentucky, accounts for 217.5 in about 100,000 population. So people always ask me, why we need to have a clinic with special focus on women's heart. What is the difference between women's heart and men's heart? When we look at coronary artery disease, well, many times, the presentation is different. And also people are not aware that coronary artery disease is the #1 killer in women as well. And females, because of their special stages in their lifespan, also have specific risk factors associated with pregnancy and menopause. And many times, looking at females, they get less aggressive modification on the lifestyle and medication prevention, resulting in higher mortality rate. And their treatment options many times are not optimized, so which resulting in worse outcomes as well. Talking about presentations, the textbook description of heart attack usually referring to heart attack happening to males. In females, weeks before they have heart attack, many of them do not have chest pain. The most common complaint we hear in clinic is fatigue. Even at time of heart attack, only half of patients presented with chest pain. Like our case, patient initially presented with indigestion, and luckily we did not stop, and we keep pushing, and we found that she does have significant blockage in her left circumflex. Like I mentioned earlier, many females will go through pregnancy, and we will all go into menopause at some point, which are associated with special risk factors. Adverse pregnancy outcomes, referring to like if you have prior pregnancy loss, or when you give babies earlier, defined as preterm birth or early preterm birth, or even the birth weight of your baby is smaller, defined as less than 10th percentile. The official diagnosis name is intrauterine growth restriction, meaning smaller baby at birth. These are all adverse pregnancy outcomes. They are associated with increased risk of cardiovascular disease, needing special attention. Hypertensive disorder is the most common, cardiovascular disorder we see during pregnancy. A meta-analysis looking at more than 3 million patients, including about 200,000 preeclampsia patients, found out that after 10 to 15 years, the woman with preeclampsia still have increased risks of hypertension, ischemic cardiomyopathy, or ischemic heart disease, and their risks of strokes is increased, and overall mortality is increased as well. So to prevent people having preeclampsia, in September 2021, the U.S. Preventive Services Task Force has published guidelines or recommendations to use aspirin, which recommended to initiate after first trimester and continue all the way until delivery for females with 1 or more than high risk factors or more than 2 moderate risk factors. The update is knowing, we actually this time considered their ethnicity background or income status or the way they get conceived. So Black race is considered a moderate risk and low income. It's also considered a low risk factor, and IVF is considered a low risk. It's also considered a risk factor for developing preeclampsia. So make sure you give aspirin, but in the right timing. Otherwise, the gestational diabetes is also associated with increased risk of having diabetes after you give birth to your child, or increased risk of having hypertension or strokes or ischemic heart disease. So knowing that if any pregnant female during pregnancy developed hypertensive diseases, including, gestational diabetes, preeclampsia or eclampsia, or HELLP syndrome, or even if they were having chronic hypertension, or the baby developed intrauterine growth retardation, or if they gave birth earlier, prematurely or early prematurely, or unfortunately they developed placental rupture, or the patient can just be obese, if they have sleep disorder or just maternal age at about 40 years old, they should be seen in cardiology clinic 3 months postpartum, or be focusing on their history and physical examination and order lab tests appropriately to screen for cardiovascular disease to reduce or mitigate the mortality from cardiovascular disease later on in their life. Talking about menopause. So the reason menopause increased cardiovascular risk is because of estrogen withdrawal. So there is a pooled analysis published in 2019 looking into more than 300,000 women. They have actually goes into menopausal early, having either premature menopause defined as going into menopause before age of 40, or early menopause defined as having menopause in age between 40 to 45, or relatively early menopause, because average menopause age is 50 years old. So relatively early menopause is defined of having menopause from age between 45 to 50. They actually have increased risk of having non-fatal cardiovascular disease. Other things, we see particularly in obese females are polycystic ovarian syndrome, which, is associated with increased risk of developing metabolic syndromes. So many times we recommend metformin in addition to oral contraceptives or birth control pills to reduce cardiometabolic, complications for this population. And because they are at risk of having cardiovascular disease, so we also recommend to screen cardiovascular risks in this special population. Autoimmune disease is more often seen in women, especially the lupus and rheumatoid arthritis. So they are apparently associated with accelerated coronary artery disease and the microvascular dysfunction. So in females with lupus, we see more than 5 times increased risk of having coronary artery disease and heart attack compared to age-similar counterparts. Otherwise, in rheumatoid arthritis patient, we do see about 50% increase of risk of cardiovascular mortality. So that's why, we've been trying different anti-inflammation agents such as statins or interleukin-1B receptor antagonist, trying to see if we can use them to prevent or reduce cardiovascular mortality in these patients with autoimmune disease. Otherwise, looking at traditional risk factors, such as hypertension, female still has increased risk compared to male patient. So we have to be very aggressively controlling their blood pressure. The published new guideline in 2017 from AHA now recommended a therapeutic blood pressure target of 130/80 millimeter mercury, regardless of sex. Otherwise, we do want also making sure people look at their lifestyle, do not ingest too much sodium, which can increase blood pressure. So sodium intake should be limited to less than 1.5 grams per day instead of 2 grams per day. Or you can have to be more than 1 gram per day reduction if you're looking at a reduction, range. So otherwise, if you are giving antihypertensive medications to young female before menopause, make sure you counseling your patient on the possible teratogenicities of your medication, such as you're thinking of ACE inhibitor or ARBs or ARAs. So be very careful, spend some time talking to your patient of potential, contraception, or making sure they take birth control pills when they are on these medications for medical necessity. So we also know that hypertension become more prevalent in females after menopause, and we also see more osteoporosis in females after menopause. So actually, one of the antihypertensives called thiazide diuretics is a good medication to reduce calcium excretion and prevent osteoporosis. So if your patient, your elderly female patient, does not have urinary, incontinence, you may consider diuretics to help them managing blood pressure and give them benefit of preventing osteoporosis. Diabetes in women actually has increased 2 times of increased risk of having MI or strokes compared to men. And young females having higher insulin resistance during their early childhood to puberty time. So that's something we have to be aware of. And mortality from cardiovascular disease and incidence of heart failure is also higher in women with diabetes compared to men. So make sure you be more aggressive controlling, the blood sugar level in female patients. Looking at different society, including ADA, the American Diabetic Association, ACCAHA, and ESU, European Society of Cardiology, we have some discrepancies regarding the target value of HbA1c, the target value of hypertension, blood pressure control, cholesterol, especially the LDL levels, and even aspirin use. So, we need to solve these discrepancies, but to just point it out, many times aspirin use for primary prevention is not encouraged in general population, but like American Diabetic Association pointed out, in people with diabetes, we still give aspirin, low-dose aspirin to prevent cardiovascular disease. So this figure actually illustrates the new guideline from 2023 for more preventive purposes regarding cholesterol level. The previous one, we had was pretty complicated regarding what we should be using to control the cholesterol levels and whether the statins should be used or not. So this one, the purpose of the update is trying to summarize and simplify all the recommendations for primary prevention and secondary prevention purposes. So to inpatient, using or needing cholesterol control for primary prevention, meaning without known coronary artery disease, you look at their age first. For men, usually start at 40 years old. For female, a little bit younger, 10 years younger. So starting at 50 years old, right after your menopause many times, and then you do the calculation of the ASCVD score, looking at your next 10 years risk. If the risk is low, you are relatively okay, can get away from the statins and just focusing on your healthy lifestyle. Then we will calculate your risk in about 5 to 10 years. On the other end, if your risk is high, meaning more than 20%, in addition to continue healthy lifestyle, then we would discuss cholesterol pill, the statins especially used, and we prefer high intensity statins. Talking about high intensity statins, we only have so far 2 available, which is Lipitor, but at dose of 40 to 80 milligram a day, or Crestor, the other name is rosuvastatin, at a dose of 20 to 40 milligram daily dose. Okay. So otherwise, nowadays we have new agent. Other than just the statins, people ask about when do we consider taking the Zetia or PCSK9, all those questions. So depends on, if they can tolerate statins, whether the LDL at goal or not, we can make recommendations accordingly, especially in people with coronary artery disease. So if their LDL, goal is still above 70, then you would, in addition to the maximized of cholesterol, the statins, the high intensity statins, then you would consider adding that here to the regimen. And in addition to that here, sometimes you can refer the patient to the lipid clinic and that get or evaluate for PCSK9 inhibitor to get the cholesterol better controlled. Otherwise, like I pointed out, that here is a non-statin cholesterol lowering agent, which is relatively not bad, modest level can reduce LDL by about 10 to 20% by suppressing the cholesterol absorption in your intestine. So many people actually tolerate better compared to the statins. It can be in addition to it, or sometimes really cannot tolerate statins, then you can go directly to the DAT here. Otherwise, PCSK9, is a we have multiple choices nowadays, are monoclonal antibodies, and they have been shown, to be very beneficial based on the big clinical trial, the Odyssey, the Fortier, to reduce the LDL level further and reduce the cardiovascular major events. So in pregnancy, then the question is, we know that statins can be teratogenicity, can cause teratogenicity. So we always wanted to consult our patient. If they were already taking the statins, they may want to consider stopping it if they have a plan to expand their family. Typically, we recommend to stop taking the statins 1 to 2 months before they attempt pregnancy. If the pregnancy is unplanned, then the statin should be discontinued as soon as the pregnancy is known. Don't wait until they see your cardiologist. So if you encounter your patient in your OB clinic or family medicine clinic or internal medicine clinic, make sure you take actions and tell them don't take anymore. Okay? Otherwise, during pregnancy, the way to manage the cholesterol level is by advocating for healthy lifestyle. If it's really out of control, then you can consider bile acid sequencing like cholestyramine. That is relatively safe for pregnancy. Talking about aspirin therapy again, we know that aspirin can subsequently reduce, events in about 25% of women if they have already established cardiovascular disease. But based on, the new data from the WHS Women Health Study or ASCEND or ARRIVE or Aspirin trials, so the new guideline coming from ACC and AHA in 2019 actually does not recommend aspirin to be given for primary prevention purposes in most healthy patients. Okay, that's a big change, so be aware of that. That being said, if patients' age is between 40 to 70s and they are at high risk when you look into the ASCVD score, meaning more than 20%, and then you look at their bleeding risk, they're relatively low risk of bleeding, especially in people who are still a smoker or having a very strong family history of premature coronary artery disease, or still elevated cholesterol on suboptimal treatment with statins or the new available agent. Or if you order just by curiosity, you ordered a cardiology or a calcium score to investigate the coronary artery disease and you see coronary artery calcification, then, you may want to discuss with your patient whether they wanted to be considered taking aspirin for primary prevention, but this is more individualized plan, not a general recommendation from us anymore. So when do we need to hold aspirin? So if you look into the patient's history, they have a history of GI bleeding, or they have a known bleeding disorder with severe liver disease, cirrhosis, coagulopathy or thrombocytopenia, or they have to use anticoagulant for other purposes like atrial fibrillation, or they have to take NSAID for joint pain, or even the blood pressure is out of control, like in above 180 range or 200 range, no matter how many medications they're taking, then you may want to be very, very careful when you give the aspirin for primary prevention. So altogether, this figure actually summarizes how we use aspirin nowadays for preventing cardiovascular disease in women. The green light meaning, it's good to go if they already know, have coronary artery disease. So this is not considered primary prevention, it's considered secondary prevention. So the answer is yes. Or if they already had stroke or mini stroke, or even have peripheral arterial disease, the answer is yes. But if they're very healthy in general, no, major cardiovascular risks, and especially in elderly, age above 70 years old, which is usually associated more with high risk of bleeding many times, or even they have prior bleeding or at risk for bleeding in primary prevention, many times we will say no, okay? In some cases, you just have to consider, discuss case by case, depending on their condition for primary prevention. Like I pointed out earlier, if they still smoking cigarette, if you see, calcification on your calcium score, or strong family of having coronary artery disease, or cholesterol level is not right, or very high coronary artery risk by calculating the ASCVD score. And then knowing that their risk is low for bleeding, then, weighing the risk and the benefit, then you can make a decision to go ahead, give aspirin. Otherwise, talking about postmenopausal hormonal therapy. I many times encounter patients in my clinic, postmenopausal, getting bothered by vasomotor syndromes, and they've been very curious, wanted to know whether they should or it's safe for them to take hormonal therapy, especially whether, that's beneficial for cardiovascular disease preventive purposes. The answer, unfortunately, is no. If you just wanted to take hormonal therapy for preventing cardiovascular disease, we do not have any big clinical trial being able to show beneficial result, favoring using of hormonal therapy postmenopausal. And instead, it's associated with increased risk of venous thrombosis if you go with hormonal therapy, except if you use transdermal estrogen, which is less associated with thrombotic events. So psychological stress, we see actually more often in females. Females are more vulnerable to emotional stress, and they have high exposure to the stress many times, and it's in an adverse place compared to men. So we see more often, depressions or adverse, early life experience in females, or social economics, status is poor compared to men, even they can have PTSDs many times, we see that more often in females compared to male. So we wanted to make sure we go support them more robustically and screen, the cardiovascular risks more aggressively in those women compared to men to mitigate cardiovascular mortality. So overall, the take-home points for this case, it's don't forget cardiovascular disease is still the #1 killer in women. And cardiovascular disease or heart attack many times in women has very atypical presentations. So maybe, it's making more difficult to diagnose. So don't stop right away, and make sure you investigate and help your patient out. That could be also the reason, of females getting appropriate cardiovascular care later, or getting some delay in appropriate care. So don't forget, in females, other than traditional risk factors for coronary artery disease, such as hypertension, diabetes, high cholesterol level, metabolic syndrome, women also had specific risks associated with pregnancy or menopause, okay? So any pregnancy complicated by cardiovascular problems, such as adverse pregnancy outcomes, hypertensive disorders during pregnancy, or gestational diabetes, they should be seen in cardiology clinic 3 months postpartum to go through all these risk factors, making sure we do what we can to reduce future cardiovascular events. And at the bottom, I wanted to tell you that long-term use of hormonal therapy to prevent cardiovascular disease is not recommended by our society. All right, that concludes our case number 1. Now let's move on to case number 2. This time we have the other age. We have a young lady who's 29 years old, is African-American female. This is her 5th pregnancy, and she's currently 34 weeks pregnant. Otherwise, does not have much, except she had a leap in January 2016 for mild to moderate dysplasia, and a colpo in August 2016 with moderate to severe dysplasia. And she presented with sudden onset dyspnea and chest pain when she was getting into her car. So she went to the ER, we drew labs, the first troponin was negative. Everybody is happy to see that. And her BNP level looks good, which is very reassuring. And then look at her CBC, you notice that she's mildly anemia, which many times we see in her stage of pregnancy, partially due to dilution. You have more plasma than your RBCs, but not too bad. Hemoglobin is still 11. Then you look at her liver kidney function, both looking good. Then, because of the chest pain, we get an EKG, and strikingly, as shown here, you see ST segment elevation in V1, V2, V3, and also AVR, suggesting that the proximal LAD or distal left main probably is having troubles with reciprocal ST depression in the inferior leads, like lead 2 and lead 2 and 3, as you can see here. Okay, so because of that, patient is rushed into the cath lab. Since we were suspecting having something going on in the left side, so we shot the right coronary artery right away. No surprise, right coronary artery looks great on the angiogram. Then when you engage your catheter to the left main, as pointed out by the red arrow, you can see the distal left main gets dissected. So coronary artery dissection, especially spontaneous coronary artery dissection, can happen when you have a collection of blood or hematoma formed between the intima and adventure, or sometimes just because the intima gets torn apart, then the blood just flow behind it, into the area or space between the intima and adventure, causing the narrowing of the lumen. And it's accounting for about a very small number, 1 to 4% of the ACS case. In pregnancy, we see that mostly at the 3rd trimester or a month after delivery. It's the most common cause of pregnancy-associated MI. So when you see a pregnant female coming to your ER complaining of chest pain, they can have MI because of the spontaneous coronary artery dissection. Don't forget about that. The risk factors associated with it could be intense Valsalva or exercise, or sometimes labor and the delivery, or exogenous use of hormone, like you're taking hormone replacement therapy. And we know that a couple conditions like fibromuscular dysplasia or pregnancy, parity, meaning multiple pregnancy, are all being associated with spontaneous coronary artery dissection, not mentioning all these connective tissue disorders and systemic inflammation disease. So the most common presentation is chest pain, and many times we see STEMI, even though occasionally we'll encounter arrhythmias like ventricular tachycardia or ventricular fibrillation. The question after seeing that coronary angiogram comes like, what do we do now? Do we need to put a stent in? Will that cause more further dissection to the distal part of your coronary arteries or not? So we have a couple clinical series or cohort to help us making a diagnosis, or not a diagnosis, making a reasonable therapeutic treatment plan. So the reason many times, we the treatment of SCAD is different from regular or common CAD due to plaque formation. It's because the PCI technical failure rate is super high and complication rate is very, very high as well. Like I said, when you put a stent in, when you put a balloon in, when you try to expand your balloon or stent, many times you dissect your arteries further to the distal part or even proximal part occasionally. So which can make the whole picture even more complicated. Not mentioning that when we did, Mayo Clinic did looking into the healing, process in SCAD patient, promisingly, half patient demonstrate angiographic healing with repeat catheterization in about 2.5 years, which is very promising, meaning if you go with medical therapy, if patients do well, they may heal up spontaneously later on. So there is a hope for medical therapy. That's why the guideline recommend for coronary artery disease, coronary artery dissection, we need to look into a clinical picture. So if clinically they look okay, and the anatomy on the angiogram is not high risk, meaning not involving the distal left or not involving the left main or the proximal two arteries, you might be safe to, just observe and give them medications for treatment. But usually we recommend them don't discharge them too quickly. Make sure give them enough time because the course can go back again. So monitor them, for at least 3 to 5 days before you discharge them. That being said, if anatomically they have left main dissection or proximal to vessel dissection, then you have to look into clinical picture. If patient is very stable and, echo looking fine, even though with these dissection is not too bad, ejection fraction still normal, sometimes you may consider just medical therapy, but another, possibility is consider CABG instead of doing PCI. If you really wanted to go with PCI, you may want to find a very skilled operator, to have better chance of not having further complications. On the other hand, like our patient, if you have ongoing ischemia or if the patient is not hemodynamically stable, then you are burned. There's no other choice to back off, wait for medical therapy. You have to do something. And sometimes you just have to go ahead to do the PCI or urgent CABG and just get it fixed to save the life of your patient. So other than fixing your coronary artery, the next question is, this is a pregnant lady. What do you do regarding her pregnancy, when to deliver and how to deliver this patient? That's our specialty, right? We work closely with maternal fetal medicine to make sure a patient going through with cardiovascular disease, going through a labor and a delivery safely. So if they had an acute event like this, typically delivery is recommended to be postponed if possible for ideally 2 to 3 weeks at least. Whether they can get epidural or not depends on the medication they're taking, whether it can cause complication with bleeding or hematoma or not. Many times, neuroaxial anesthesia is contraindicated if you are given them P2Y12 agent, such as Plavix or other agent. We usually only use Plavix in pregnancy because data are less with other agents like Efient or Brilinta, because it can cause spinal hematoma. So in general, we like to wait if possible until, a baby's lung gets mature after 35 weeks. Nowadays, 37 weeks is considered early preterm. So many times we like to move delivery a little bit earlier, which is easier for the mom and safer for overall the condition if baby is mature enough. If we are considering induction, many times, with cardiovascular condition, okay to consider induction at 40 weeks for all women. Otherwise, exactly when, like I said, you have to consider the mother's condition, and then you have to evaluate baby's behaving, the maturity as well. Then talk with maternal fetal medicine make a decision altogether. Talking about modality of delivery, looking at the ROPAC data, elective C-section many times is not recommended because there's no maternal benefit and usually associated with early delivery and low birth weight. And many times we still encourage vaginal delivery because it's associated with less blood loss and lower risk of infection, lower risk of venous thrombosis and embolic events. That's still recommended for most women. Otherwise, talking about induction is associated actually with reduced risk of emergent C-section and risk of stillbirth. So many times we do encourage. C-section, is usually we are reserved for the most risky patient, for people like when they presented, they were still taking oral anticoagulant for those, or they have very aggressive aortic pathology, such as like really huge, aortic root or ascending aorta, or EDS patient, with vascular type, or patient is, having refractory acute heart failure, or with very severe pulmonary hypertension, including Eisenmenger's, then you would consider C-section, get the baby out very quickly. But in general, we still encourage vaginal delivery and induction can be considered. Otherwise, you have to consider baby's head direction, and usually, to avoid compressing the vena cava, we favor, decubitus position when they are going in labor. And for some of the cardiac patient, if they have, let's say, some valvular disease, mitral stenosis, you may want to consider shorten the active phase of the second stage. Consider assisting the delivery with a forceps or ventures to reduce maternal effort, but sometimes can cost some damage, in the cost of fetus injury. So otherwise, how do we induce labor in people, in patient with SCAD? So mechanical induction is definitely okay. And the oxytocin is also all right for a SCAD patient, but typically we do not recommend misoprostol or dinoprostone because of possible coronary artery vasospasm or hypotension associated with these two agents. Should we monitoring the patient or not? Yeah, many times we do like to know the blood pressure and heart rate, in patient with cardiovascular disease. You can, but don't forget, if you put patient on telemetry, many times, the telemetry bed, it's very rare in OB world. And if you put them on telemetry floor, then they kind of away from the expert, like the OB group, which is not safe for those patients when they are, going into labor. So being more, creative, thinking of using, continuous like pulse oximetry to monitor the oxygen heart rate if needed, instead of putting them on telemetry all the time. If the patient has severe heart disease, then consider an A-line to monitor real-time dynamic blood pressure. It's also recommended. And definitely you always wanted to monitor the baby's heart rate, when you make those decisions to help you knowing which direction to go, okay? And postpartum, because the significant hemodynamic change and the fluid shift within the next 48 hours, many times we like to monitor them, especially for heart failure patients. You need to monitor them at least 24 hours, sometimes up to 48 hours postpartum to make sure they'll do all right. And infant monitoring also many times it's 48 hours, which will work out just fine. So postpartum, many females also, it's complicated the delivery by hemorrhage or bleeding. So in a patient with SCAD, it's okay to have a slow infusion of oxytocin, just like earlier when we use oxytocin for induction, it's acceptable. So otherwise, we do not like to use Masogen because it can cause hypertension, which can add a lot of pressure for the coronary artery system or myocardium. And also, in addition, it can cause vasospasm. So definitely a no-no. After you deliver the baby, your job is not done yet. You still have to look into a few things, you know. You have to talk to your patient, asking them about breastfeeding plan and how much they can do physically, you know, and what they wanted to use for birth control, right? You need to look for the future, not just stop right away right here. So regarding breastfeeding, many times be aware that if they are taking the P2Y12 agent, breastfeeding or breast milk is not encouraged, okay? But aspirin alone, low dose, it's okay. So do they have recurrence if they have SCAD? The answer is yes. 10-year recurrency is about 29.4, meaning about 1/3. Average year of recurrency is about 3 years. So don't feel like it's all fixed. It may come back, so be aware of that. And interestingly, when you look into the anatomy, 80% of the recurrent SCAD is actually happening to a new vessel, not the old vessel, which is very interesting. And when we break down into the details, we know that many times the recurrency is also seen more often in a patient with fibromuscular dysplasia, or if they, was using hormonal therapy, or even in people using statins. That's why many times people with SCAD, we do not always routinely discharge with the statins. So looking at all these risk factors and beneficiary factors, we found out that in patients with SCAD, hypertension definitely making things worse. But if you place them on beta blocker, which actually prevent recurrency, which is great. So do not forget that beta blocker is your friend in SCAD patient as well. Otherwise, they'll ask you how much we can do. So make sure, don't forget to refer your patient to cardiac rehabilitation, which will help them coping with the situation by getting in, emotional support and learn, new ways to cope with their life. So yeah, cardiac rehabilitation with the cardiac events. Otherwise, how much can they do? Weight training wise, typically for females, you wanted to limit to less than 20 pounds. For males, usually less than 50 pounds. Otherwise, try to avoid lots of Valsalva maneuver, for example, weightlifting. That's why we don't want to give them too much weight. And usually exercise, activity wise, we tell them guide by their symptoms. If they feel okay, not too short of breath, keep going. Right? But if you have chest pain, then you stop. Don't keep forcing yourself to go forward, okay? Otherwise, if you had spontaneous coronary artery dissection, many times we discourage you from high intensity activities like very competitive sports or contact sports. Regarding, you already learned about recurrency. So talking about recurrency, we need to look into contraception, right? Because if it recurs, then you kind of don't want it to go through this cycle again because it's associated with pregnancy. So many times we do encourage people consider, tubal ligation, or, husband doing the same thing, basically sterilization. It's highly recommended, but otherwise, if you really cannot do it or don't want to give up that option, then if you need to consider birth control, many times we would like to avoid estrogen containing birth control. Progesterone containing birth control, it's all right, or IUDs. So for the pregnancy, usually it can recur. That's why we do not recommend further pregnancy. That's why we encouraging birth control or contraception, okay? That is the main reason. So quickly going back to our case again with that lady, she was really unstable. She went into VFib, she was shocked 5 times. So she was loaded with aspirin, antibiotics, and become hypoxic. We gave her Lasix right away. We eventually, because of that, we could not opt for medical therapy. We have to proceed to PCI. Luckily, we have a very skilled operator, and the result was fantastic. So it's shown right here. You can see the coronary artery looks beautifully without looking like there's no injury at all, right? So good job. So we did echocardiogram. You can see from this echocardiogram. Sorry, it's not playing all the time, but basically what it's trying to show is the apical area with aconnect, but the rest of it is still moving okay. So she actually did relatively well, even though her troponin eventually peaked at 192. So because of that, we have her rested a little bit, and then we did C-section in the cardiac cath lab on day 5 when she turned into 35 weeks. And it was a little bit complicated by hematoma, but she did well after a PRBC transfusion with discharge home with DEPT and the carvedilol and also ACE inhibitor captopril. So the take-home point for this case is SCAD is the most common cause of pregnancy-associated heart attack, and usually seen in the third trimester or months after delivery, and patient can present with chest pain, and many times it's NSTEMI. Really, we also see STEMI in our case, or ventricular arrhythmias. Many times, if patient clinically is stable, then we recommend medical therapy after seeing the anatomy in the cath lab, and beta blocker usage can prevent recurrence of the SCAD. Otherwise, talking about delivery and the modality have to be based on each individual presentation and the stage of pregnancy. But in general, we like, if possible, to postpone their delivery for a couple of weeks to have the mother recover from the acute events. And after they, had this event, many times we recommend cardiac rehabilitation. But overall, we'd like them to avoid strain or Valsalva maneuver if they have to lift weight no more than 20 pounds for females. And don't forget, SCAD can recur, and the 10-year rate is relatively high. It's a third of them. That's why we encourage contraception or birth control. And if you think of birth control, you don't want to do tubal ligation, then, making sure you avoid estrogen-containing contraceptives. And we do not encourage subsequent pregnancy, and make sure we control blood pressure well to prevent recurrence of the SCAD. And that's it. Thank you so much for listening to this presentation. And if you have appropriate patient, please refer the patient to Women's Heart Program at Norton Heart and Vascular Institute. We are located in Plaza 3, 3rd floor. Our suite number is 301. So here is my contact information, and I have a group of doctors working with me, including Dr. Lauren Albers and Dr. Logan Abley, who is specialized in congenital heart disease and mainly localized in Norton Downtown Hospital. And we also have a APRN, Emily Shutt. So we work as a team, and we will help you managing your patient. Any questions?
Thank you so much, Dr. Zhou.
You're very welcome.
I see one question in here, but it's actually not a question about your slides or the clinical aspect of them. It's actually from one of our labor and delivery nurse educators at Women and Children's, who said she'd love to have a copy of your slides if possible,
Sure.
to help educate her staff. So
Yeah.
Angela, if you could just email Dr. Zhou, then I'm certain she could get you a copy of these slides.
Yes, I will. If you send me the email, I'll give you the slides. Thank you. I'm glad
I very much appreciate, much as I did when you presented at the primary care update, how comprehensive you were, and the cases that you did were great. And I think it gave a really good overview of all of women's heart health, both the peripartum work that you do and the prenatal work that you do, but then also the more later in life work, like your first case. So I think the reason we don't have other questions is you loaded people with so much knowledge that they can't even think of a question right now. So
thank you, Dr. Jennings.
I very much appreciate your time today, and I think everyone, like myself, learned a lot.